Hi everyone, my topic is pica. That's what I will be discussing today. So to start off with, we have the Dsm-5 criteria. So the first one is that there's persistent eating of non-nutritive, non-food substances over a period of at least 1 month that is severe enough to warrant clinical attention. Sometimes people like to eat things that they shouldn't, but that doesn't mean that it is severe enough to have a diagnosis. With people that have pica, there's typically no aversion to normal food. They just crave and ingest these substances because they want to, not because they're picking it over actual food. They just like the way that it tastes. They also may need to expand what is considered non-nutritive, non-food substances in the DSM because vinegar is technically food, but that doesn't mean we should be ingesting it a lot. Or what about rotten food? Like, what does that mean for the diagnosis and things like that? Some examples that people commonly ingest are pebbles, cigarette butts, coins or change, and then soil. There is an episode of My Strange Addiction where a woman was eating her husband's ashes, so that was very interesting. One thing that they know is that the eating of non-nutritive, non-food substances is inappropriate to the developmental level of the individual. So it's encouraged to not diagnose this in children under the age of 2 because kids put things in their mouth. That's just what they do. So they don't want to be diagnosing like typical developmental behavior. So they want to make sure that it's not just kids being kids, it's actually something that's going on that needs to be treated. Additionally, the eating behavior is not part of a culturally supported or socially normative practice. So in Western Kenya, eating soil is a part of everyday life. So someone in this culture that's eating soil would not be diagnosed with pica because to them that isn't disordered eating or atypical, that's a part of their culture. And then the last criterion is that if the eating behavior occurs in the context of another mental disorder, like an intellectual disability, autism spectrum disorder, or schizophrenia, or there's a medical condition, including pregnancy, pica has to be sufficiently severe enough to warrant additional clinical attention on top of pica or ingesting of non-nutritive, non-food substances, typically within these other conditions, enough to have a separate diagnosis. Some differential diagnoses are anorexia nervosa, factitious disorder, and non-suicidal self-injury, and non-suicidal self-injury behaviors and personality disorders. However, it's difficult to diagnose pica in general because people don't think to ask about non-food consumption. So people are not in an intake being asked questions, what non-food substances do you consume? People may hide it very well, so it's hard to diagnose it in general unless someone's caught doing it. So the anorexia nervosa, it's the eating of non-nutritive, non-food substances as a way to control appetite. So people ingest paper towels to fill up their stomach so they're not hungry or they don't have room for food. So here the eating of a non-food substance is a means to control their appetite, not because they want to ingest paper towels. And then additionally with factitious disorder, it's ingesting foreign objects as a way of making yourself have physical symptoms. So it's a means to have physical symptoms, not because you want to eat something that's not food. And then again with the last one, you're ingesting potentially harmful items like pins, needles, or knives to hurt yourself, not because you want to eat them. It's just like, again, why people are eating what they're eating is very important in the diagnoses. Comorbidity, so disorders most commonly comorbid with pica are autism spectrum disorder and intellectual disability. My mom used to work with patients that had severe intellectual disabilities, and she can attest to this. Additionally, pica can be associated with trichotillomania, so hair pulling disorder, and then exoration, skin picking disorder. So the hair or skin is typically ingested in these cases. So they pick it and then they eat it. Also, avoidant restrictive food intake disorder. So people that are really particular about the sensory component of food and how it feels, how it smells, how it tastes, that may play a role in this as well. People that are very picky eaters of like actual food might also have pica because They just are so limited in what they eat. We're not really sure about the prevalence, again, because people don't think to ask about non-food intake. So what we do know is that pica occurs in both men and women. It typically starts in childhood, but it can begin at any age. And then among individuals with intellectual disability, prevalence appears to increase with condition severity. And this study found that 21.8% of individuals with an intellectual disability had pica as well. Another study found that it's most common in underdeveloped areas with low socioeconomic status, in pregnant women, so they crave ice or chalk cravings while they're pregnant, and then in children, but that typically decreases as they grow older. So kind of like what I was saying earlier, kids just like to eat stuff that they shouldn't, but you have to make sure that it's clinical eating of non-food substances, not just kids being kids. There's a lot of impairment that's associated with pica. It's pretty severe, so it can lead to gastrointestinal problems, poisoning, acute weight loss, and death depending on what was ingested. So it may only take one time ingesting something to have severe consequences, because if you are ingesting a household cleaner that has bleach, that could kill you or very close to it, or if you swallow a bunch of razor blades, that's not good for you. It's going to tear up your insides, you're going to have ulcers, you could bleed out. It's very scary. So because of this, the goal of treatment should be to eliminate pica completely because it's so scary and the consequences are so severe if the wrong thing is ingested. So like people that eat gum, when they swallow it, it typically will pass, but if you're eating like packs and packs and packs of gum, that's going to build up and have some, you're going to have some stomach problems. And then pica is only identified sometimes following medical complications. So if this person has just been swallowing their gum all the time and they eat 6 sticks of gum a day, and then they have physical discomfort and they go to the doctor and they get an ultrasound, then they might be able to link why that was happening. But sometimes people just don't pair the two together. There is an impact on others, so it might be difficult to watch your loved one experience complications from consumption. There could be a lot of hospitalizations, there could be a lot of doctor's visits, and healthcare is not cheap, so there's a lot of costs associated with that. They may die. It's hard to watch anyone die, but especially knowing that it's because of them swallowing something that they shouldn't have, that's awful. And then also most treatments require the inclusion of others, so people sometimes have to be monitored 24/7 to make sure that they're not going to hurt themselves, and that falls on caregivers to be able to monitor them and be trained in the treatment so that they can implement it outside of like an inpatient setting, and so when they go home, the treatment gains are still maintained. And then additionally for the individual, they may hide their cravings and their consumptions from others because it's embarrassing, so that may lead them to socially withdrawal, and then that may lead to them having depression and other symptoms that are not good. So it's kind of like the snake that eats its own tail. It's a lot can happen. There are a couple different etiology hypotheses. They're not super sure about where pica comes from, but these are our best guesses. So cultural practices, kind of like what I talked about within Western Kenya, people started eating soil and then it just became a thing and they do it now. Sometimes it has health benefits, sometimes it is for fertility reasons, things like that. And then there's a neurological model, so maybe there's something in our brain that plays a part in this, maybe damage to certain areas that was done in studies with rats found that. And then nutritional hypothesis, this is probably the most notorious one that has the most attention given to it. So this is the idea that we are lacking in certain minerals, and that might be why we're prone to eating soil or something, because we're lacking whatever the soil has. And that is most commonly the case in typically developing individuals, but more research needs to be done to determine the effectiveness of mineral supplements as treatment. The hypothesis that I will focus on with the treatment is the behavior analytic hypothesis. So this states that pica is a learned behavior and that there's also a stimulus control problem. So people have this craving to ingest non-food substances and they have a hard time handling that craving, and then they give in and then they keep doing it again and again and again. And also some people may not be able to differentiate between food and non-food substances. So that plays a big role too. People just don't know what they're supposed to be eating and what's not edible. The maintenance of pica, there might be a connection between pica and obsessive compulsive spectrum disorders. So the need to ingest substances are similar to obsessions, like those intrusive thoughts of eat the soil, eat the quarters, something like that. And then once they ingest it, it's similar to a compulsion. So once the substance is ingested, it provides relief from the need or craving, so that's negative reinforcement. However, when they consume the substance, it's usually not associated with decreasing anxiety or stress or prevention of a feared outcome like most compulsions are with people that have OCD. Additionally, a person may like the taste/feeling of what they're ingesting, and so they're going to keep doing it because it tastes good. So there was an example in a chapter that I was reading where a woman liked a specific color and brand of nail polish because it tasted the best, and so she kept eating it because she liked it. And we do the same thing with our favorite foods. So I love chicken strips, so I eat chicken strips more and more because I like the way that they taste. And it's the same thing for people with pica too. They like it. There are some treatment complications that I need to discuss. So pica treatment is labor, time, and resource intensive, and so research has typically been limited to inpatient settings. People sometimes need constant monitoring, like I mentioned before, and then most of the research that we do have is case study based with 10 or fewer participants. Most of the research that I saw had 2, 3, 4 people, and each case is different because pica is very individualized. It's different for each person. And then if an individual has a caregiver, like small children, they have people that look after them, and then people with disabilities, those caregivers also need training to continue the treatment once they leave the inpatient treatment facility. And then the treatment outcome is also partially dependent on caregiver dedication and involvement too. So it's not just the individual, it's the caregiver that's helping enforce the treatment and continue those treatment gains. So there's a couple different treatment approaches. So first you want to start with a functional and behavioral assessment to better understand the person's maintenance factors and potential obstacles. So like I said, pica is very individualized, so you need to know where that person is at so you can meet them where they are with your treatment. And then it works best if the treatment is generalized across contexts and caregivers. So again, that inhibitory learning of just creating more pathways for learning to try to extinguish that craving or desire to ingest non-food substances. So some examples are discrimination training, so learning what you can eat, what you can't eat, response blocking, blocking them when they try to eat something they shouldn't, aversive stimuli, so something that tastes really bad when they eat it, and then physical restraint, which is literally restraining them so they can't eat. And then differential reinforcement is what I will talk about today. So differential reinforcement is currently the most practical treatment model supported, and also there's support for behavioral treatment in typically developing children. So the behavioral treatments are probably the best way to go. And then pica is considered an operant behavior that's sensitive to environmental consequences. So people that do pica sometimes want caregiver attention or oral stimulation. So you have to disrupt that in order to treat the pica and extinguish it. So the current study had 2 participants aged 9 and 16 with autism spectrum disorder, and they preferred different substances. So first they started with item disposal training. So they taught them how to throw away things that they shouldn't eat and that you shouldn't eat these things. So first they just are teaching them what they need to do. And then once the treatment starts, they encourage item disposal and reinforce with something edible / praise them after completion during the interval. So they have several different treatment intervals, but the children don't know when they will be rewarded. So they're encouraged to just constantly do it and learn that new behavior. And then the people giving the treatment also want to block pica behaviors when they can so that the people are not ingesting the non-food substances. And then you need to gradually decrease hovering to generalize to natural environments. So try to be less and less involved so that people learn that they can do it on their own. And then afterwards, you need to have follow-up treatments in the home to ensure treatment gains are made with the caregiver after treatment. Thank you.